examples later on. Now again, this is what I copy-pasted from the American College of Radiology. I didn't invent this. It says, occult fracture, it's not radiographically apparent or demonstrates subtle abnormalities. And they are initially missed on radiograph, on the interpretation. So do we have to miss some x-rays fracture? Yes. We are human beings, we can just do it. Now most of the time, probably in Egypt, you will have actually a patient who's coming and has, you will have a missed fracture, probably they don't do anything. Unfortunately, in the country where I'm living right now, it's usually lawsuit, and it's usually a lot of money going on. So essentially, when someone will come and he has fracture, he's willing actually for you to miss the fracture, because at the end, he will get some money. And I will show you two examples where we missed actually the fracture and we got actually lawsuit, unfortunately. Now this is, again, by definition, it can be easily overlooked when diagnosis is based on plain radiograph alone. That's absolutely the case, when it happens. And it's confirmed by other imaging modalities, or if plain radiograph is, visualized or seen or interpreted in retrospect. So the residents in my hospitals, they always do the same thing. You have a patient coming with pain. What they're gonna say is there is no radiographic, there is no radiographic fracture, but they said if clinically indicated and the patient is really of high suspicion of fracture, a CT scan on MRI may be indicated. So that's actually the whole thing, because they put it there, it's much more legal than anything, so they don't want to just really be in a problem getting actually into a lawsuit. Radiography is the first step. I mean, everybody knows about that. I don't want to just really introduce that, but I want to just say that the technique is really very important. And again, I'm going to be really playing it actually, as I said all the time, we do a very good imaging on CT in my hospital. We do a very good imaging on MRI. We do a very bad job on X-ray. Very bad. I mean, you sit with me on 150 patients that will come with X-ray, and you will see that more than 2/3 of the X-rays are bad. And I don't know how to do that, how to deal with that. I'm the chief section of musculoskeletal. I go every day looking after the technician. I explain to him how to get the X-ray the best way, and next day they will do the same thing. So I am exhausted after 6 years and a half working in the same actually department. I'm exhausted in a state of fatigue, not stress fatigue, fracture, but really in a state of fatigue that I don't want to deal with this anymore. And what I do, if I don't see the fracture, I put their CT or MRI is indicated. That's what I do. I know it's not maybe the best way to do it, but that's actually what's happening. We have 35 techs, 35 techs that are working just for the MSK, turning around for the MSK section. We have 150 techs in total. I'm not going to teach them, and reteach them, etc. They are not willing to do the good job. That's actually the problem. Hopefully, actually, your department is better actually than our department. Now, you need to have two orthogonal views. That's absolutely, the case. And sometimes, depending on joint, you may have actually obliques. I do think knowledge of normal anatomy is very important, and there is that big book, very famous book of Theodore Keats, that every single department of radiology has because of those normal appearance, etc. I mean, you know about it. I do think it's the most, famous book in radiology. Every single department has that book without any problem. Now, systematic interpretation is really very important, and I do that all the time, and I'm not teaching really here the seniors, but if there are juniors, and I hope there are so many of them, and orthopedics, they're not radiologists, I will say normal anatomy is really very important, and systematic interpretation is really very important. And that's, for example, for the elbow, or for the ankle, and I do think Mark Schweizer will actually talk about that this afternoon. I mean, when you look at the fat, it's really very important. The fat pads in the elbow, the fat pad actually in the ankle are very, very important. Of course, the experience is very important as well. I mean, of course, we gain with experience, we gain gray hair. Okay, at least we have something better than those guys that look better than me because they don't have gray hair, but at least they don't have actually the experience they have in radiology. Now, when it comes to magnetic resonance imaging, is probably the best exam after the X-ray, because it shows you the whole thing, the whole spectrum. It shows you the stress fracture, the the insufficiency fracture, but also the contusion, bone contusion, and of course the stress reaction. Now, very important to know as well is most of the time you cannot do it because maybe you don't have insufficient time for the MRI, etc. That's what happened to us as well. So patients sometimes can get in the MRI very quickly, sometimes cannot get to the MRI. But quite honestly, I do think it's really very important to know. I will show you some examples, and especially if you have a hip fracture, even the CT is normal. You need to go for the MRI if the patient has pain. And if we have one unique sequence that we have to do in this case, should be T1 weighted, because you have T1 weighted non-fat saturated. So you have the fat is a normal content of the bone marrow. If you see anything which is black, hypointense, you know that there is a fracture. Okay, so this is a really unique sequence that is very important and mandatory for the kind of interpretation. Now again, I will repeat that so many times. T1 weighted, non-fat saturated is your best friend for fracture. And as usual for any bone marrow abnormalities, that's really the best sequence. If you need to do one sequence, that's the sequence you want to do. Usually a fracture, that's what I put here, it's really very important. When you have a fracture and an acute fracture, you have always soft tissue abnormalities. That's absolutely understandable. Now the CT is of course good as well, and it will show you that sharp lucent line within the trabecular bone. But again, as I said, sometimes the MRI will show that bone marrow abnormality, that subtle fracture, sometimes without fracture, so it will be stress reaction, bone contusion, that are very important information for the referrer physician that the CT scan will not show you. So I do think if you have the opportunity after the X-ray and there is high suspicion of a fracture, go to the MRI as the next step. Now I'm going to talk actually about upper extremity and lower extremity, and I will show you so many examples. It will be much more a catalog, much more actually as a picture review together about actually acute occult fracture. Now, when you look at that, the upper extremity is dominated by the scaphoid, and that's why I put from this publication from 2006, scaphoid injuries are 60 to 70% of the upper extremity of the carpal bone, and then 10 to 15% of the scaphoid fracture are overlooked or missed, and that's really very important. We see this in my department, we see this every week. Every week we have missed diagnosis on the CT. Sometimes it's the radiologist, most of the time because of the nature of the scaphoid and the anatomy of the scaphoid, very difficult. Even with those focal or scaphoid view, you can actually miss that kind of fracture. So you really need to know about it. And if you have high suspicion, go to the MRI, because you cannot wait with the scaphoid. If you wait 1 week, one of the pole, and especially if you have a mid-scaphoid fracture, you're going to have an osteonecrosis of the bone, and then it's completely useless to intervene at that point, because what you're going to do is going to be, of course, a carpal, I would say dislocation there, and you're going to end up with the patient having a carpal fusion because you cannot do anything. Pain will be always there. So make sure that you really think about the scaphoid fracture. If you don't have anything on X-ray, patient is really very painful, and high suspicion of fracture, go to the next step, MRI. Now for the radial fracture, they are seeing 14% of an MRI that clinically suspecting a scaphoid fracture. That's actually by this scientific publication by Cunningham. So you do a MRI for a scaphoid fracture, and you find an MRI fracture of the radial of the radius. That's in 14% of the cases. So some cases here together. And if there is anybody who sees something that I don't see, please let me know. This is actually the scaphoid 26-year-old male after assault, and we have a lot of assault in Boston. As you can see, we just jump on each other, and try actually to kill each other. So when you are in Boston and you're living in Dorchester, every night there are at least 2 to 3 people killed and maybe 10 to 15 gunshot, and some of them they get actually also assaulted. That's a very typical night in Boston, surrounding Boston. So you don't need to be really there. There is a very tiny subtle line of fracture here, and if you look at the scaphoid view, you don't see anything. And this is 12 days later, because we didn't see it. What happened is, as you can see, osteonecrosis, probably the proximal pole. Now the fracture is visible. They put screw, but as you can see, really very dense actually proximal pole of the scaphoid. The outcome of this patient is very bad. It was not very good, unfortunately. And you understand why? Because collapse of the proximal pole, collapse of the whole carpal bones, and end up with a fusion. 26-year-old male. Now another case where you don't see anything on the scaphoid view and you don't see anything on the lateral view. That's the 18-year-old male soccer player after fall. Now, very high suspicion of fracture of the scaphoid. We said we're not going to stop there. We did a CT scan, as you can see on coronal reconstruction. You have a small line here. You see it, but on the MRI it's way better seen. Here you see the line. You see the hypointensity of the scaphoid on the bone marrow here. This is a T1 weighted, non-fat saturated. This is your best friend, as I said before, because with this you have the diagnosis of the fracture, you have the hypointensity as well, and the edema on the distal pole of the scaphoid. Now, if you have time, of course, you can go for a coronal view or sagittal view, and you see very well the fracture line, hypointense, and the hyperintensity of the scaphoid. But if you have no time and you have the opportunity to do an MRI, with one actually, of course, sequence, the T1 weighted, non-fat saturated sequence is really your best friend. Now the triquetrum is really also very important, and you can see this all the time. If you do only a plain film and AP view, you don't see anything most of the time. But it's very interesting to see that there is actually, of course, here some bone by itself on the dorsal aspect, what we call chip fracture, which is very typical for a triquetral fracture. Now this is much more, I would say, subtle. You see here, always actually show this, and I show it so many times in different countries. I really don't know what does mean semi-professional, BR player without trauma, but if you have any idea, please let me know. That's how the patient introduced himself. I know, an amateur, maybe like me, I play some, from time to time, once a year. There is a professional who's playing every day, semi-professional, and I didn't understand it, but that's how the patient presented himself. So 14-year-old male without trauma, but he's playing beer all the time. And what you can see here, a very subtle, maybe periostal reaction, you see it here on the spot, but very subtle. It's not really that much of visible. There is no line of fracture at all, and I don't see any line. And the patient was painful, so we turn actually, of course, to the CT scan, and very surprisingly, we see that there is a very thick periostal reaction. It means that really it's not acute. It's something that happened a long time ago. So there is a chronic periostal reaction here with probably chronic fracture. On the top of that, there is a very thin line here, which is loosened, and that's probably an acute fracture. So it's probably an acute fracture superimposed on a chronic fracture. And you see the second of all, we've done an MRI. Again, really T1 weighted, non-fat saturated is very important. You see the line here. You see the soft tissue, also edema as well. You see it on T2 better. And you see a big, large, acute hyperintensity indicator of bone marrow reaction, and bone marrow reaction which is acute. So again, by CT scan, you see that the cortex is very thick. You see that there is a very thick periostal reaction. So it's really chronic kind of fracture superimposed with a acute fracture. Now, this is a patient who came after fall on ice. We get the radiograph. Unfortunately, I could not actually fetch it. He did it in another hospital, but the radiograph was normal. And 1 week later, he came back, almost with the same pain, So, you know, the referrer orthopedics thought that maybe it's something happening into his rotator cuff, maybe a rotator cuff tear or maybe labral tear. He said there is no fracture, so probably that's what is painful for a patient. Send them for a MR arthrogram. And we started with the arthrogram. I just want to show you this arthrogram. There is nothing. It's really normal, I would say, fitting of the joint. And you don't see anything here on the upper or superior larger tuberosity. But when you look at the MRI, you see maybe the slap lesion here. There is a slap lesion anterior posterior. That's really not really a big deal. The big deal here is with this T1 weighted, non-fat saturated, you see a line, fracture line, and you see the line very well on the T2 with bone marrow lesions. So that was not feasible at all because it's not displaced. Okay, you see it's not going maybe to the cortex, the other side, maybe here a little bit. Very subtle fracture that nobody's seen on the greater tuberosity, and that's what happened most of the time. If you think that the patient has a suspicion, a high suspicion of fracture, you maybe hear a good indication, a MR arthrogram, you can see everything at the same time, but essentially the patient is painful because of the fracture that was overlooked on the X-ray. Now the pelvis is really very important anatomy location for the fracture. And it's very difficult for us as radiologists. I mean, I'm talking to the orthopedics because most of the time, I know there are so many of you here, most of the time you look at the radiologist and you want to just see what happened here on X-ray. It's very difficult for us. And for three reasons. The first one is that the anatomy is a little bit difficult, it's all curvatures. The second is the superimposition with all the gut and all the air in the gut, etc. And then the third one is especially the osteopenia. Osteopenia would render that very difficult interpretation. And most of the time when you send patients, they are actually female and they are postmenopausic, and most of the time they have osteopenia. So really very difficult to grasp actually a fracture in the pelvis. Sacrum is actually maybe the location that you're looking at, and that's, as I said, very difficult. I do think sometimes you need actually to be aware that those stress fracture or insufficiency fracture, they are very difficult, especially in female postmenopausic, to be assessed on an X-ray. So I'll show you some examples. 61-year-old female, renal osteodystrophy, fall from the wheelchair. You may actually look at this forever. I will just give you the image and a tweet here. Please look at it for 3 years if you want, and send me an email later on. Let me know if you see something, because there is none. But when you look at the CT scan here, you see that subtle fracture here on coronal reconstruction and axial also images. You see really a fine line of lucency on CT, which is of course the fracture. There is no, here with all actually the, my interpretation here, I don't think there is anybody who can see something on the sacrum on the X-ray. Now this is even more difficult because we turn it around. Young female, atraumatic buttock pain, steroids for 9 years for SLE, so for lupus. And as you can see, there is nothing. We look at this image, several times retrospectively. And when you look at the MRI, of course, you see very easily within this stir sequence coronal image, you see the subtle line of fracture surrounded by a big bone marrow edema. You see it here as well with the bone marrow edema. And you see it on the T1 weighted, non-fat saturated again, line here and the bone marrow edema. So sometimes, I want to just really, I would say, draw your attention to this. Sometimes when the lines are bilateral, you have bilateral fracture of the sacrum, and if you go very quickly in the interpretation, I saw that 2 or 3 times, especially with residents, they look at it very quickly and they think that this is actually an articulation. I mean, of course, right now I'm showing it this, but you see this in 10 MRIs when you interpret, and it's bilateral. You may actually overlook that fracture, and it happened, a few times here. And I want to just draw your attention to this. I mean, the line is parallel to the articulation itself. It's a very thin line, hypointense on T1, T2. Make sure that you look at it really, and you see that fracture as demonstrated here. Another actually patient with a coccygeal actually pain with 3 weeks. You look at the coccyx, it's absolutely fine and normal. The sacrum, there is no problem at all. And the only thing we can see here is the left sacral, left ilium that is here at hyperintensity on T2. That hyperintensity you can see on T2 or as well on axial images, and that's what we call stress reaction. So stress reaction is definition, by definition on MRI, is that hyperintensity without any fracture line visible on T2 or T1, and that's actually what we call a stress reaction at this point. The pubic ramus is again something that we sometimes miss. This is a patient, 61-year-old female after fall, pelvic pain. We looked actually, of course, at the femoral neck, and there is nothing. I do think maybe you see something retrospectively here from this image. So the spot is here, maybe something, maybe not. But when you look at the CT scan, you see a line fracture here, not subtle at all, but of course without displacement, you see the line of fracture on the pubic ramus, and that's actually very, obviously a very no subtle fracture, I would say, on CT, but it was not visible on the X-ray. Go back, sorry, one slide. You see maybe retrospectively that maybe here there is a small line or lucency on the pubic ramus, but we didn't see it. We overlooked on the X-ray, and when you indicate here the CT scan, you see it very well. We wanted actually to do the MRI for the patient, but she was claustrophobic. And again, you may see here some actually avascular necrosis for the patient. Now this one, we see a lot of them. We have a lot of accidents, a lot of MVP, motor vehicle collisions as well in Boston. They drive like crazy. And if you come to Boston, try to drive actually anything but not a car. Really very crazy people there. And I would say very aggressive, like European style, not really like California where people will drive very, very gently. In Boston they are very crazy and they drive very, very fast in town. And we have a lot of dashboard accident, and what happened, you have actually a fracture and posterior dislocation of the hip. I saw so many of them, but this patient came with a fall. So 49-year-old female pain after fall, and quite honestly, I see actually the fracture, of course, here without any problem. We overlook because the patient has so many things as well. He has trauma to the lung. He has a lot of multiple fracture of the ribs. He has a spleen fracture. So essentially, we have so many things in the patient that we overlooked actually the fracture at night by the resident. The next day, when we look at actually, of course, the CT scan, we see very well the fracture, posterior fracture of the acetabulum. Now, this is again 25-year-old male soccer player with groin pain. So we've been looking at muscles, muscle injury on the groin. We're looking at any stress fracture. We didn't find anything, but very surprisingly, we found actually at the posterior acetabulum. You see here on these sagittal image and axial images, you see this, the same hyperintensity T2 without any fracture line, and that's of course what we call again a stress reaction. So it's still a stress reaction. We call it reaction, as I said, is an MRI definition of course a contusion to the bone without fracture. The lower extremity fracture, we're going to talk about the femoral neck because it's the most common, as you know. We see this all the time, and I show you some examples. And as I said, it's really very interesting to say to the orthopedics that we can miss them because of the anatomy, but also because we have osteoporotic hip most of the time. They are female postmenopausal, so if they are osteoporotic, very difficult to see fracture, and especially when you have that heterogeneous punctiform, I would say, patchy osteoporosis that we see sometimes. Also the presence of osteophytes, because you're dealing with someone who's old, so most of the time you can have very big difficulty to see this kind of fracture. When it comes to MRI, the sensitivity for detection of and specificity of detection of fracture, it will be 100%. That's by the article published by George Alcouri from Iowa University. We know as a radiologist, it's really very good actually method to diagnose fracture. of the hip. Now, most importantly, as I said, again, if you have one sequence, it's the T1 weighted non-fat saturated. That's really your best sequence. If you can do both sequences, you can go for a T2, of course, because what are sensitive, it shows you actually the edema and the extent of that bone marrow edema, the soft tissue also abnormality, and it will show you again the fracture line, which is in hypointense T1 and T2. Now this is a good example, and I show it to a lot of my colleagues in the United States, and they were actually like, a little bit, I would say, freaked, because when you see this, you can just, say, okay, this is a bit big, herniation pit, the herniation or synovial herniation pit, and this patient, very typical for that. It's actually lucency surrounded by some sclerosis. It's really at the junction between the head and the neck. It's really typical for what you look at the synovial herniation pit. So no problem at all. The patient has a cancer, prostate cancer, and he has atraumatic pain. So is anybody here can see something happening to the neck besides the herniation? It looks like normal. No. 1 week later, because the patient is still having pain, we brought him to the hospital. We get actually the CT scan, and as you can see, there is a line of fracture going through that herniation pit. Of course, you understand that it's so big that make actually the bone fragile, and that's what happened to the bone. It just broken into a fracture. So again, if you have a high suspicion, okay, of fracture in a patient with pain, traumatic, atraumatic, get him a CT scan and MRI, because that's what you're going to find at the end. Now this is a 55-year-old male, atraumatic left hip pain. Do you see anything? I don't myself. So you have the spot image, okay, here. You look at the neck, you look at the head, there is nothing. When you look at here at the MRI, it's very easy. We did actually a bone scan before, and you find very well here there is actually a hyper intake there, or uptake of the scintigraphy, technetium 99 marked technetium scintigraphy or bone scan. You see it very well, and on MRI it's very obvious. Again, the T1 weighted non-fat saturated is your best friend. You see here the line, you see the line of fracture, you see the bone marrow edema. You see the bone marrow edema better on the T2, of course, but again, there is a fracture. It's non-displaced, and that's why maybe it's very subtle to see on the X-ray. Now, this is a patient a little bit more complicated, because the patient is 47-year-old male with pain on the right, and we know that he has an AVN. He's been under corticosteroids for leukemia, and of course, you see the AVN here, very obviously with a collapse of the articular side of the femur. There is no doubt. I want you to go on the spot image and look at this, because this is where the fracture is. I'm going to tell you that, okay, because I know about it. But we looked at the head, we looked at, of course, at the neck, we looked at everything here, and we didn't find anything. And when you look at the MRI, you see this is your T1 weighted non-fat saturated image. You see the fracture line going from the greater trochanter to the lesser trochanter. You see that line with the, the bone marrow edema on the T2. And again, if you look at the image here, you don't see anything going on the, on the greater to lesser trochanters. So what I'm saying, I'm giving you this catalog, and we see this all the time. It's just when you have a high suspicion, patient has a change in pain. This patient has pain, yes, because he has avascular necrosis. But he's coming and he's saying, I have change in pain. My pain is worse. I don't know what's happening. Just get him something else than actually the X-ray. If the X-ray, of course, is negative. This is a patient with 28-year-old male with right side growth pain. Not the same patient. This is actually a football player within university, Boston University. Is a football player with the college. And as you can see here, there is no fracture line at all. This is a T2 weighted again, and T1 weighted non-fat saturated. You see the edema, the bone marrow edema, but you don't see the line. And of course, in this case, you can say this is a stress reaction. That's really per definition. Now, one thing I want to tell you, if you see this in a patient, now this is very easy because growing pain, he is actually, of course, a football player. But let's say someone who is 28-year-old male. He will tell you, I have pain, this pain is recurrent every night, it's new, it's worse at night, if I take actually aspirin and just kill that pain, what you're going to say probably osteoma, and it looks like this, by the way. It's a good location for it, but there is no reaction to the bone in this case. An osteoid osteoma, usually you see it very well on X-ray, because you see that lucency, you see, of course, the reaction of bone, which is not the case here. You see the cortex is very normal, and there is no actually soft tissue, a little bit here, but there is no really big soft tissue edema like you see it with the osteoid osteoma. But that's really a very good location for that small tumor. Now this patient, the diagnosis is very simple, because the patient has a very new actually growing pain. Now when it comes to the knee and lower extremity, we see a lot of this. And this is where we get the maximum ourselves. In my department, this is where we get a lot of lawsuit, I would say. I'm going to show you, I think, 2 examples, but really we have a lot of lawsuit, unfortunately. We get, I do think, more than 50 cases of fracture with big fracture, and we do actually surgery on them, traumatological actually surgery, kind of fixation of the tibial plateau per month, which is really big, huge numbers. But we get these actually also subtle fracture in the knee, and most of them, they are on the lateral compartment, as you know. So it can be either the lateral trochlea or the posterior lateral tibia. This is where you see the maximum, and that's by nature, because this is concomitant to ACL tear, as you know. So either you see fractures or you see actually contusions. And there is an article in Radiology from this year in I think February or March, by Rick Kiofsky, who is from United States, from Wisconsin, who looked at retrospectively at patients with ACL tear, and we overlook, radiologists, with looking at the MRI. When he looked at those images retrospectively, looking after fracture, we overlook more than 45% of those. So you have the MRI, you have the ACL tear, you have the images, you look at them and you don't report a fracture of the trochlea or fracture of the tibial plateau. And after I read that one, I started myself to really put a lot of importance on that and look at the T1 weighted, non-fat saturated very, very well. And this is where I find actually the images. I'm going to just repeat this, because when you look at the images, you look at the T2, very well, protein density, fat saturated or non-fat saturated. Why that? Because it gives you all the information. So we'll give you the information on the cruciate ligaments, on the collateral ligaments, on the menisci, on the bone marrow. But you don't look at the T1 weighted. We acquire the T1 weighted that I don't look at it at all myself, to be honest. But I look at the T1 weighted now when I have a suspicion of bone marrow infiltration, or I have a high suspicion of fracture. I look at it, make sure that there is that actually thin line we talk about, which is the fracture. Now this is a case where you have a 20-year-old male, after 14 stairs, he's a medical student. He falls the 14 stairs directly, brought him actually to the emergency room. And if you look at the images, there is nothing. I mean, you can just look at them back and forth, there is nothing. And this is a CT scan. A CT scan, because he is actually a medical student, we have actually a CT scan right away for him. And as you can see, it was normal. So nothing seen on X-ray, nothing seen on the CT. But when you look at the MRI, you see the hyperintensity on the trochlea, you see the hyperintensity on the posterior lateral tibia, exactly what you expected usually. This is actually, of course, the medial femur. And we actually, of course, got a diagnosis of bone contusion. So bone contusion in my hospital is exactly like any fracture. They split the patient, they tell him to not walk anymore on his knee for at least 2 weeks. Sometimes a little bit more, 3 to 4 weeks. It depends about really the importance of that actually contusion. But this is by definition a contusion. That's why you don't see it on X-ray, you don't see it on CT. Now this is the patient, 49-year-old male struck by car. He has so many other pathology, I have to tell you. I mean, his abdomen was actually filled with pathology of grade 4, liver laceration, splenectomy because of fracture of the spleen, multiple rib fracture, intubated the patient, etc. So we did actually also an X-ray because it was painful. You see the joint effusion here. But you know, obviously it's a very subtle, maybe right now retrospectively, fracture here, you see it here as well, you see the fracture, but it was very, very difficult. This is an overlooked fracture by the radiologist. Okay, so a colleague of mine, a senior colleague, MSK, didn't see it. And what happened 1 week later, the patient cannot actually ambulate. When he started a little bit actually to be awake, could not ambulate, and you see the MRI now, there is no doubt there is a big fracture with a collapse of the lateral tibial plateau. Unfortunately, big bone marrow edema, as you can see, big contusion. We get a lawsuit, the patient get $5 million in his pocket. Big money. 20-year-old male regular jogger, again, I will say, if this is going to be, again, in my list, in my past, myself, I will miss it again. Quite honestly, to be humble and not saying, yes, I can see it, etc. I didn't do actually the interpretation of this one again, it's a colleague of mine, but if I have to do it again, myself, I will miss it. Very subtle. As you can see, the spot will show you a very, very thin periosteal reaction, almost not seen. Okay? That's why I said I will myself just, you know, miss it again. And it says 20-year-old male regular jogger. And this is what happened when you look at the CT. There is a very thin line here, the periosteal reaction. Look at the bone marrow edema on T2. Look at T2 here, sagittal and coronal. And you see really a very important on T2 here axial. You see a lot of bone marrow edema, a small line here. You see the bone marrow edema on T1 and the line of fracture very well on T1. You see it on coronal all the way. So you see the fracture very well on, you know, on CT. You see it very well on MRI. It was not seen on the X-ray. Just that very thin periosteal reaction. I will finish with the lower limb and fracture to the ankle and foot. And I will say that the talus is actually the one where you find in the neck and the dome where you find actually the maximum of occult fracture. Of course, the calcaneus is one that fracture a lot, but most of the time we see it on X-ray. We see actually that change in the angle, so we see really very much actually the fracture of the calcaneus on X-ray. We do CT because we want to just see surgically how we're going to just deal with it, and if it's intra-articular or not. But most of the time we see the calcaneus fracture. But the one that we miss mostly are the talus, because it's a little bit complex as an anatomy and configuration. Now, those are actually the guys where, you know, the gymnasts and runners, soccer player, where you find the maximum of lesions, so you need really to make sure that you don't miss those. And when you have a chance to go for an MRI again, please do it, and I'll show you some examples. So this is a 13-year-old male soccer player with ankle twist, and as you can see, there is a soft tissue swelling. I do not see myself any lesions there or any fracture, and even retrospectively. And when it comes to the CT scan, you see that there is a fracture here going Sutter 2, Sutter Harris 2. When you see the fracture here in the medial malleolus, and you see Sutter Harris 3 visible here in the distal fibula. So again, very, very commonly when we don't see anything, because it's not displaced fracture, you see it on the CT scan, so go for a CT scan if you have any problem to figure out if the patient has a fracture or not. A second patient, 49-year-old male with after fall. The only thing that we saw, of course, some soft tissue swelling here. When you look at the spot image, there is a tiny bit here, very thin periosteal reaction. A very thin periosteal reaction, that's what we see. And when you look actually at the MRI, you see on the T1 weighted here, you see that subtle, small here periosteal reaction turned to be a very acute line of fracture on the T1 weighted image. Again, this is really the best image that you can get, a T1 weighted image. And you see on the T2, the bone, the extent of bone marrow lesions. So a lot of acute edema in the bone marrow. Also, the bone scan shows you the same fracture. So again, when you have high suspicion and you don't see the fracture, if I go again here, you see there is no fracture on the tibial extremity, but there is a little bit of periostal reaction, as I said, and that's about it. And a few weeks later, the patient with the fracture on the X-ray. So if you expect to wait for a month and repeat actually the X-ray, that you're going to say, probably you want to just do the diagnosis before that, and that's what happened. You know, 1 day later on the MRI, you can see it. This one was overlooked on 39-year-old male with after fall, so we didn't see it. Retrospectively, of course, you see very well the fracture. There is no displacement, there is no rupture of the cortex, but you see it here very well on the reconstruction on sagittal images. And again, so sagittal images on CT showed very well, while the here the AB view, we could actually, of course, see retrospectively the image of the fracture that we overlooked on the in first place. 25-year-old male sportsman, pain and no trauma. You look at the image back and forth. We are looking at the talus, trying to find out if there is anything with the talus, but it looks there is nothing. And when you look at here at the talus again 1 month later, there is nothing. But when you look at the MRI again, it's going actually in small pieces here. There are complex tear here on the dome and on the body of the talus with a lot of bone marrow edema, as you can see here. So again, really, if you have high suspicion, you don't know what to do, just go to the MRI. That's your best bet. I'm going to finish with a few images very quickly. Calcaneus here, there is nothing. Even though the calcaneus, as I said, is really easy, usually you will see it. But sometimes, again, it can be misleading. So the calcaneus here is completely normal, and look at the view here, really, you can see everything about the calcaneus. You'll be very surprised when you see this. It's really all over the place. It's extra-articular, intra-articular. It's actually with a lot of, I would say, displacement, so that it's comminuted fracture with a lot of displacement. We don't see anything on the X-ray. And again, my message here, if you have high suspicion, you don't see anything on the X-ray, go to the next CT or MRI, and better if you go to the MRI. Navicular here, a patient with history of osteomyelitis, but with pain without trauma. And you see the navicular here very well. You see it here, there is nothing there. You see the navicular here, there is nothing on the X-ray. Very surprisingly on the MRI, the T1 weighted here, very high point dense, and the line is quite visible. The T2, the line of fracture, and the big bone marrow edema. Again, really very surprising that you don't see anything on the X-ray, but that's actually what is the occult fracture. To finish with is a 26-year-old male with a soccer player who is sprained of ankle. We looked actually at everything here. I can tell you it's happening in the fourth. You can see, there is nothing at all, and that's because it's all about bone marrow. So on the fourth, there is here nothing but bone marrow. Okay, bone marrow edema. You see here the bone marrow edema on T2. You see it on T1. Sorry, you see it on T2. You see the bone marrow here, there, and so this is what we call actually much more about contusion. So it's or stress reaction if you want, because it's no trauma. So stress reaction, that's what happened to the patient, and that's why you don't see it on X-ray. So I do think the conclusion was actually during my talk that I said, if you have an occult fracture, a very high suspicion of occult fracture, don't wait, don't actually lose that time for the patient, because it can be really quite painful at some point for the patient, and also for the institution if they have to reimburse the patient money for a lawsuit. So go for the CT scan, go for the MRI. You have to talk to your orthopedics, but essentially don't wait actually until the patient get actually displacement of fracture. Thank you.